we actually have one of the largest healthcare practices globally. And we do work in the federal sector, believe it or not. We actually do get hired by the federal government occasionally. We also have we'll use this kind of as our backdrop. We have a life sciences practice, which is where I sit. So I'll introduce myself first and then let my colleagues do the same. But believe it or not, the Medicare Catastrophic Coverage Act of 1988 was the first entitlement program that's ever been repealed by Congress. And I started my career working actually for McKesson and PCS, the pharmacy benefit manager. So after it was repealed, I ended up going to work for some of our clients in research and doing pharmacoeconomic and business intelligence and analytics, and then that got into commercial strategy. So I've spent 25 years working in the life sciences sector, cross pharmaceuticals, cross med device, cross biotech. And Ashwin mentioned two things, collaborative and speed to market. Those are two terms that I would never use to describe my sector ever. We are not collaborative. We are very much the independent scientists when we look at the R&D, and I would say we do things really well to discover something, but then bring it to market. We spend 10 years out of a 17-year patent life cycle eating it up to get it to market, and we don't kill something when we think, you know what, it's really not, I can't even get it out of animal studies, but I'm going to still go and spend another $600 million bringing it to market. So it's an interesting sector, and it's had to change. And I don't think accountable care and the intent behind it, which was providing access and providing better quality and lowering the cost, is really what's brought all this to the forefront. The Accountable Care Act was really a reaction to something that's been going on for 25 years. And finally, I think my sector, and we'll share some thoughts about that and how we can incentivize some collaboration with the provider and the payer sectors to really drive this cohesively together. But this is something that's really been a trend that we haven't been able to tackle. And I know specifically on the manufacturer side, we haven't done anything to really impact it.
Sure. Hi, Derek Robinson. I'm a manager in our healthcare provider practice at Deloitte, and I had envisioned standing in front of you today saying I'm wearing the hospital CFO hat. And then I really got to thinking through some of the comments that were made earlier today, some of the comments that made around the complexities of healthcare spend. And I don't know a hospital CFO, and I typically spend my time up and down the West Coast and the West region of the United States with hospital CFOs and health network CFOs that isn't just thinking about the hospital and how they can maximize for the hospital, but also has urgent care centers that they're responsible for, has clinics that they're responsible for, has physician practices that they are allied with, and has a population health management program, and is starting a health plan that is intended to, in some sense, keep out and manage the health and well-being of the very patients that 10 years ago, that CFO absolutely wanted to come through the door as fast as possible. So it's a much more complicated hat, I would say, than hospital CFO. And what I'll try to do today is just help think through a little and help you think through a little what those CFOs that have a much more complicated set of issues they think about today than they were 5 or 10 years ago, really what's top of mind and how do they think through the economic case and the value proposition for a device? How do they think through the economic case and the value proposition for an alliance? A little about me. I've been with Deloitte for about 5 years now. As I said, I do all kind of large enterprise transformation work for hospitals and health networks here in the West. And what I've been seeing out in the marketplace is a tremendous focus, a focus that's kind of going like a hockey stick on the cost of delivering care and how I, as a CFO, can motivate my organization to deliver that care more cost effectively as very, very quickly the world is changing on our feet. So very happy to be here today.
My name's Alan Young. I'm actually a physician by training, born and raised in Canada before coming to the US to study. Was trained in orthopedic surgery and moved into a position with Kaiser Permanente, a well-known HMO here in Southern California for the past 4 years. Joined Deloitte and really joined their national provider practice, started working with physicians, physician leadership, CMIOs, people who were really concerned about the impact of the Affordable Care Act and other initiatives that were impacting clinical care. So what we've been seeing is a lot of work in the space around adopting advanced electronic medical records, trying to keep up with meaningful use requirements, trying to adopt to ICD-10, which is coming around a year from last month. Looking at things as physician process improvement and looking at just really what their day-to-day activity is like, focusing in primarily on what they do as a provider, but what information needs to be drawn out of their activities to allow the rest of the hospital system to function. A lot of it is focused on their documentation and also their ability to see patients in a meaningful way and apply technology that's being introduced as we move forward into this next phase of healthcare reform. So really I want to focus on these 4 areas and really kind of give you a perspective of what are the challenges and opportunities from a provider perspective. So really around the area of access. We talked about the amount of patients that are now going to enter the system because of the requirement to have insurance. As you know, there's been an outward pressure for physicians to no longer pursue primary care as one of their main options coming out of medical school. If you did a survey today of medical students and say what specialty they'd want to go into, I think the percentage is almost down to less than 10% would go into primary care, given the nature of the environment it is in. Not only that, there's a huge opportunity for other providers to fill the void, and that's where there's going to be a lot of transition where we have advanced practice nurses, chiropractors, physician assistants, mid-level providers will be assuming primary care roles, and that's going to really change the access. And we mentioned Bill's presentation earlier really highlighted some of the things that are really the backbone of this. What are the shortages in nurses and physicians projected moving forward? How is that going to affect the ability to deliver cost-effective care if you have a limited supply of providers and you have to pay them a premium to even provide basic services? So really, the next step is really to look for cost-effective alternatives, and that's where technology may play a huge role. We talked about the cost. That the U.S. spends a significant amount more than other countries based on prescribing medication, ordering diagnostic tests, putting referrals, admitting patients for limited reason or limited medical necessity to really face in this environment what we call a medical legal issue as well. There's a lot of backlash against physicians. It's more, health no longer been seen as a privilege, it's seen as a right for every individual to be seen and be taken care of. What that's resulted in is a lot of care being given that may not be necessary to ensure the patient's care, but really to satisfy requirements, maintain a level of care that prevents the organization from being at risk. So this risk sharing really takes place when you look at the private practice physician who has a large malpractice overhead versus joining a system like Kaiser. They assume that responsibility. You see more and more consolidation in the industry as providers are saying, it's no longer viable for me, given all of this reform, to face the challenges of being a successful entrepreneur or private practice physician. I'd rather give up that autonomy, assume less risk, assume less autonomy, take a pay cut even, but at least have that higher quality of life. And that's going to drive the ability for providers to see a number of patients differently as well, because then they're constrained by the organization that they work in. Next is really around quality, and a lot of the work we do now around accountable care organizations, value-based care, performance improvement, has really tried to shift the model away from what we call a productivity metric to a value-based metric. A lot of times we see physicians are no longer incentivized to pursue some further education or engage in additional coursework or take on a new initiative because they're not incentivized to do so. You try to tell your neurosurgeon, orthopedic surgeon that, hey, you need to come in and attend this extra training, you need to be adept at your medical record, you need to sign your documents at an appropriate time. They're going to say, what's in it for me? And that's the response we've had as we go around the country trying to deliver education one-on-one to physicians, to entire groups of medical staff. Really the response is, what's in it for me as a physician? I've already spent X number of years in medical school, X number of years in residency. I do not have time, I didn't enlist in this to go through affordable care and try to make a hospital system more successful. And that's really where the culture shift needs to take place, really to get everyone on board, to really see the value. The promise of an Affordable Care Act is in the words itself. You're giving care to patients, trying to improve their quality of life, trying to do it in a meaningful way that doesn't drive the system or the organization under. And the last part is really act or action. Really, people have to really take initiative, really want to be concerned about where they work, who they take care of, and their quality of life to drive these things forward. And lastly, the experience of healthcare providers has been very pessimistic over the last several years, at least from a consulting role. I mean, as a provider coming out of medical school, joining Kaiser, everything seemed okay. There wasn't a lot of downward pressure to see more patients. There wasn't a factory where we were told you got to drive out. And the mention of Kaiser earlier, we really do feel that they are a progressive system in the sense that the government is referencing a lot of our thought leadership, a lot of our leaders from Kaiser to really say what model has worked. Outcomes have been improved. They've done a lot of what we call proactive care versus reactive care. Reactive care helps drive up costs. Proactive care may reduce an unnecessary emergency room visit, may reduce an incidence of a heart attack or stroke. Even having a program such as walk with your doctors in the morning. I know at Kaiser here in Southern California, they give patients the opportunity to go on a hike around the campus with their physicians. Not many organizations would try to promote this lifestyle or wellness that we mentioned earlier as well, because that's not really cost producing. It really is cost reducing in terms of the ability to limit the future costs and be proactive to try to drive healthcare costs down, where a lot of people are just trying to curb the costs that are going out of control by limiting salaries, by seeing more patients, by trying to reduce overhead, reducing quality of the type of medical devices or products that you use, going to low-grade generic pharmaceuticals. These things are helping drive costs down, but not in a meaningful way that would be sustainable. Any questions on that? Any comments? We want to try to keep this interactive. I know there's some things that light bulbs that may go on, but please feel free to interject at any time. So looking at the context of really over the last 10 years, the cost of doing, providing care has increased. And you can see that the largest contingent is either hospital care or provider care. So you're talking about seeing patients in the hospital and the provider rendered services. So these are kind of the core components that we focus on as a consulting firm, is really to help hospitals understand the needs of not only their patients, but also what their providers need. And that is, I think, one of the biggest, kind of 400-pound gorillas in the room, that really what is it that your providers are needing. These are kind of where the challenges and opportunities come into play around technology. I think from a provider standpoint, really having all of this infrastructure, providing the technology, implementing an EMR, giving them all this new toys to play with doesn't go very far if the provider themselves are reluctant to use it. They doubt the credibility about the data that's coming through. They don't think it's going to change their patient's outcome, or they think it's just a ploy for the organization to drive up costs and as a result, take more out of their patients. One example from a client is really, expending millions of dollars in electronic medical record system, coming and say, this is going to solve a lot of our problems. One little thing they forgot to do was enlist the buy-in of all the physicians. So what happened, the physicians said, hey, we never provided any input on this. The technology looks great on the outside, but it's not what I wanted. It's not what I think is right for my patient. I'm going to continue to use paper documentation and do my orders and do my surgeries and dictate and not use your system. As a result, that client came back to us and said, we have to overhaul our system and reinstall a new one. Can you help us do this the right way? And that started with engaging the providers and getting their feedback on how to use technology in a meaningful way to not only get their input and provide it in a way that they feel is appropriate to their patient, but also bring them along board for the ride. Because the technology is something that many providers are not comfortable with. As you can imagine, using your smart devices now to look up medication information is paramount. You can't memorize these things. More and more information that is being funneled through medical science, providers are not able to keep up. And as you go through all the different channels of having nurses, medical students, pharmacists, chiropractors, physical therapists, they all rely on technology to get that information at their fingertips. And I think that is really where one of the challenges is, to change the culture to say, hey, this technology is useful, but I got to be able to apply it in a meaningful way. And who's going to teach me how to do this? You give a kid an iPad, they'll probably figure it out and intuitively know how to use it. Providers aren't so, gifted in the sense to have grown up with that technology. They're used to having documentation, reading, and interpreting information and applying it. And that's not really what technology does. Technology takes away that interpretation, and they're just doing the application sense of it.
Quick question?
Yes.
So two things. One, do you see that changing with the next generation of providers coming in, for example? And then two, as fast as technology is moving, what about the regulatory burden of trying to get that technology into these places with respect to validation and accuracy and the risk of systemic problem within results, for example?
Great question.
So maybe speak a little bit about that.
Yeah, so the first part is definitely we see a shift when we go and I present to a room of residents and interns about education. They seem much more adept at being on the electronic medical. We actually had promoted a kind of a see one, do one, teach one mentality where the residents actually will learn about the electronic medical record system, create the shortcuts, think about what would be useful for their attendings, and assist them during their clinical rounds to help integrate that in and say, hey, it's coming from someone that you're working with and has a lot more meaning, another physician telling you, hey, this is a shortcut, it'll make your life easier, you don't have to dictate 3 minutes of verbiage, you can actually create a shortcut to put that into the format in 30 seconds. So that really has a big, meaningful impact when you come to kind of that fostering that collaborative environment. Obviously, there's some providers, the CMIOs that I work with are advanced in Asia that have adopted the technology quickly, but they can say a lot of their peers are, kind of much more reluctant to do so. It is not only something to be said that if you're a surgeon for 40 years and now you're struggling trying to adopt a new medical record, you're not going to be the first one to say, hey, I'm struggling, I need help. It's much easier to say, hey, this is not working for me, I don't like this, let's not use this. It's definitely a culture change, and I've seen a lot of providers think about moving out of the provider practice because of this technology burden, requirement for EMR, requirement for all these other things as well. So that's a challenge, again, to accessibility and access to healthcare. If you have your bread and butter providers deciding to move on to the next stage of their career, you're going to be having a huge hole to fill. And hopefully, again, with the number of residents and medical students that are not increasing at the rate of the needs for primary care, that's going to be a huge challenge. But just going back, technology is being adopted much quicker among residents and fellows and the younger generation. I think that goes back to medical education and trying to integrate in using technology early on so they get accustomed to it. Now when they go to the hospital training environment, the EMR is already there. I know when I started, I was writing paper, no one could read my writing. That, those days are gone. So every medical student is starting with an electronic environment for the most part. So it makes a big difference.
How successful has the mandate on EMR submissions for reimbursement been on actually getting people to second guess their transition period? Or is it still a doctor of 40 years saying, I don't care, I'm going to do it manually no matter what, even if I'm not getting paid?
Yeah, that's great. Let me touch on his second point first and get back to you. So the second question, if I remember correctly, is really around security and privacy of using technology. I think the HIPAA has been a big part of trying to protect personal health information, and that has been a big opportunity again for technology firms to say, hey, we are capturing a lot of data, it's being transported or conveyed in electronic format, and that's an opportunity again for these organizations to think about what is the infrastructure around it. And that has been a very challenging part because we've heard a lot of stories about people leaving their systems unlocked or having information on a flash drive, and suddenly, being a laptop having been stolen at a conference or something like that. So these are definitely challenges, and I think that that's one of the things that the industry is trying to, put their arms around, because that technology is accelerating at such a fast rate that these security issues are not always forecasted, and it's again a reactionary response when a catastrophic event happens, and all of a sudden they come up with new rules and regulations. So I would say that the regulations around it are not as stringent to prevent some of these, but it's a growing process that I think is going to happen regardless.
Yeah, and Alan, I think one of the things we're finding with the FDA and computer system validation, we see more and more often folks are going into an initiative with better information about what it's going to take and what's going to be required. So we're no longer seeing the big surprises of, oh gosh, we've got to add another $2 million in the back end of this implementation of something that we didn't really think about. I think the FDA has been a lot more open to some risk-based approach to the validation, but unfortunately there is definitely data that shows that this is hindering a lot of innovation. It's definitely hindering innovation in terms of information products and the mobile health and cloud solutions. So, I think that's the conundrum that the FDA has a couple of different work groups that have been formed to really tackle some of these and figure out how do we actually foster innovation without hindering it, but also do it in a safe way where we're still, adhering to the regulations that are really there for the right reasons. But so it is something that is a current challenge, and they recognize that.
So if you think about the competitiveness, and if we admit that we live in a global economy, speed to market for us in the U.S. is constrained by the FDA barriers that could take 10 years and $1 billion for a new drug, or 10 years and $100 million for a new device.
Yep.
No other country in the world imposes anything even close to this level of regulatory oversight. So isn't it just a matter of time before we completely lose the advantage that we now claim to have in this entire sector from a competitiveness perspective?
Definitely, and I think that's where some of their work groups, they're trying to figure out. What's happening though, I think internationally, at least in EMEA, is it's not necessarily from a quality efficacy, but it's what is the comparative effectiveness. So there's a lot of countries that are denying, when you have a single payer environment or isolated, few numbers, they're denying access to their market because there's no proven comparative effectiveness. So it's interesting how here we've got a different regulatory challenge that might be hindering innovation, But in other places, some other countries are becoming a lot more stringent, especially on the drug side, and now even more so on the device side, where we used to try to launch products in Europe on the device side first. That's even becoming a little more challenging because, you know what, if you can't prove that this is more effective, and there's an economic story, and there's a comparative effectiveness story, I don't want the 6th new entrant into the glaucoma market on my list of available products here in this marketplace.
Can you just repeat your question?
So back to the transition to data gathering within the healthcare process. The mandate on reimbursement on electronic medical records being a requirement, particularly for government reimbursement and transition, has it had a real effect? How much transition has happened by the providers that have an economic now motivation to actually use the computer?
It has a big effect because we've seen the number of compliant hospital systems has increased. The slope is going upward as the deadline approaches. And we've also seen consolidation among private practice groups. And this is anecdotal, where clients have said, you know, we've been a cardiology practice for the last 30 years, maintain our autonomy, forecasting at what would be required for us to jump through all these hoops to maintain electronic medical record to test for meaningful use. We're just going to join the system and have them kind of take on that responsibility. So that has happened in isolated
and that's happened
incidences.
fast. That's the first thing in this industry that's happened
So
really
that's
fast. Yeah.
Consolidation, I
Yes.
guess, is a, yeah.
Yes, it's been the lever for consolidation, particularly in small groups, but also even, not so much in California, but more broadly in the nation, consolidation between physicians and hospitals, because hospitals typically have enough capital base to make that investment, and it's a part of a compelling value proposition, especially in the short term, when you have a physician caught between, I don't want to make the investment, but I have to make the investment in order to stay on the reimbursement train. One of the ways you can do that is by allying with a hospital that will provide that technology for a price, of course. I think there's a question back.
Yeah, based on my personal experience, my wife was a physician practicing in San Diego for a small group, which had about 20 doctors. They implemented an electronic medical records, to your point. The problem is I think the way they take their notes, I think they know cookie cutter applications more than being specific to a particular specialization, so to say. So they have trouble getting into the notes, and there is a lot of frustration because she used to spend about half hour with the patient, and now she ends up spending about an hour. And half the time when she's entering the notes, the systems crash, they don't have the network access, antivirus is not there. So the general consensus, what they are trying to get to as a smaller groups is, why do I need to go through all these and go through the health insurance? I might as well go to the cash-based system, like in any other third world country, versus trying to really put a technology in place and get the efficiency out of it.
I think this is one of the things we talk about the industry and what could possibly happen. And I absolutely respect the need for patient safety in the FDA's role, and because you can have catastrophic results, right, with devices or laboratory medicine. The flip side is I can envision a world very quickly that is moving away from the reimbursement model, especially as reimbursement continues to diminish, right? And how do you make investments if you're not having corresponding reimbursement, for example? But I look at companies like 23andMe and Ancestry.com, and pretty soon, you could do a swab, put your genome up there, and a private company for a modest amount of money, $25 to $100, can tell you a lot of things that you might be paying $1,000 to your provider for through the reimbursement model to find out if you have the CF mutation, for example, right? And when we talk about the contribution to society, so not only does that displace the current model potentially, right? But when we talk about the contribution to society, we might do a validation study of 1,000, 10,000 samples, let's say, and get some information. Once people start doing that and consenting with 23andMe and Ancestry.com and something like that, you might be able to look at studies across millions of blind patient samples and really start to make some significant advancements. So I think that while that's all very exciting, I think it's also putting a lot of pressure on the standard model, and quite frankly, it could become obsolete very quick, back to the cash pay market, to the comment the gentleman made.
And in fact, one trend that we're seeing right now to sort of accelerate that a little bit is the trend I think Ashton spoke to a little bit earlier, toward kind of high deductible and cost sharing to the patient rather than to the plan, right? Because I mean, honestly, if it's coming out of your paycheck at the beginning of the month, I think most of the people in this room are acutely aware of that. Broadly, it's not quite the same psychological effect as if you're really paying out of pocket and making a very pointed consumer decision. So as consumers shift away from these high premium, low copay, low coinsurance plans to the plan like the one I have for my family, which is a high deductible plan with a health savings account, I become much more acutely aware of whether I can make that small investment up front now and potentially save myself, a lot of unnecessary time and money down the road. So as we see, and I mean, in the Affordable Care plans, they're very high deductibles and more cost sharing than I think many Americans are used to. In the short term, that is often characterized or seen as a burden and a rising cost, but it does to some extent drive the kind of consumer behavior that you're talking about over time as consumers are more directly responsible for some of their healthcare spending. I don't want to spend too much time on this, and I think it's probably been up there long enough to soak in, but one of the things we'll try to close out with today, since this is a collaborative effort between the medical device CIOs and provider CIOs, is really what can we do to avoid that thing in the middle, which is silo-based healthcare. And a lot of the things around the periphery are areas in which the CIO's office in technology can play a pretty pivotal role. The data disconnect one, I think, doesn't require a lot of explanation, but even around wrong incentives. So if the incentive to a player in the healthcare system is reduce the cost of this intervention and share in the savings, that's absolutely predicated on a reliable, trustable source of data to prove that that actually happens so that we can confidently share in the savings. Well,
I mean, the reality is the incentives right now for both of our sectors, if you think the provider and the manufacturer side, is all volume.
Yeah.
So if I sell more product and you guys run more, do more stuff, then you get paid more, we make more money. So that's part of what has to shift in terms of how do you pay for outcomes and how do you pay for results. So that is definitely going to involve collaboration between the two sectors going forward.
Absolutely. And then that thing in the lower right-hand corner, patient connection. So going to an acute care hospital for acute services is probably the most expensive thing you can do in terms of consuming healthcare services. To the extent that technology enables monitoring and service at home in the patient setting and transmission of that information back to a kind of centralized record, that has very good aggregate cost effects. And again, it's predicated on information sharing broadly across the industry. Yeah.
Your upper right-hand corner where you have data disconnect, I assume that the largest disconnect is probably because of all the individual physician practice